You're walking up a short flight of stairs, and suddenly you have to stop. Your chest feels tight, and you're completely winded. It is incredibly common to write this off as a normal part of getting older, but often that sudden exhaustion is the first sign of heart valve disease. It is a rising cardiac epidemic that frequently goes unnoticed until it reaches a critical stage. Heart valve disease affects over 1 million Canadians and 13% of Americans over 75. The stakes are clear. Untreated, mortality drops sharply, with 25 to 50% dying annually. Yet treated patients see 94% survival with a well-functioning valve a decade later. The underlying biology is lethal, but the lack of awareness is the primary cause of avoidable death. Patients often live for years with declining health because they never realize their symptoms represent a treatable medical condition. We see this in the stories of patients like David and Mandy. David was active and playing hockey, assuming breathlessness was a temporary dip. Mandy's symptoms were completely masked by an autoimmune condition causing fatigue. They both fell into a psychological trap where patients and primary care doctors alike incorrectly attribute these specific warnings to just getting older. Avoiding the doctor during this phase creates a dangerous cycle. To stay comfortable, patients naturally stop exercising. That sedentariness leads to rapid physical deconditioning, making them even more fragile. When we normalize daily fatigue, we allow a manageable mechanical issue to become a fatal error of inaction. To understand the failure, we look at the heart's 4 critical doors: the aortic, mitral, pulmonary, and tricuspid valves. Their thin tissue leaflets open and close with every beat, ensuring blood flows in only one direction. Failure typically happens in 2 ways. First, stenosis. Leaflets become thick and stiff, creating a narrowed bottleneck that traps blood. The second mode is regurgitation. The valve fails to seal shut, allowing blood to leak backward. The heart responds by pumping harder to compensate for the leak or blockage. Eventually, the muscle strains, enlarges, and fails under constant mechanical pressure. Because this is a structural breakdown, it cannot be fixed with medication or lifestyle changes alone. Mechanical failures require mechanical solutions. Detection starts with a basic auscultation check, a doctor using a stethoscope to listen for the telltale sound of a heart murmur. Data shows a massive gap in basic care. Fewer than 40% of adults receive a routine stethoscope check. If a murmur is found, an echocardiogram is needed. Guidelines suggest a 2 to 6 week window, but wait times often stretch to over a year. Logistical delays are compounded by gender bias. Most diagnostic guidelines are based on male heart sizes. Because women have smaller hearts, they are frequently underdiagnosed and referred for treatment much later. These systemic failures turn a manageable condition into an emergency room crisis. The solution is a centralized model of collaborative care, the heart valve clinic. Here, surgeons and cardiologists work together with the patient to build a personalized treatment plan. One effective option is TAVI. It avoids open heart surgery by threading a new valve through a catheter in the groin, directly inside the failing valve. This recovery timeline shows the impact. Catheter-based procedures allow patients to resume their lives much faster than traditional surgery. The physical repair is only the first stage of recovery. Returning to a normal routine depends on professional cardiac rehabilitation and counseling to address the anxiety and mental strain that often follow heart surgery. Improving outcomes on a national scale requires policy changes, mandatory annual stethoscope checks, strict deadlines for diagnostic scans, and digital tools in primary care. Surviving depends on self-advocacy. If you feel your body slowing down, demand your doctor performs a physical exam and truly listens to your heart.